All right, good morning, everyone. I am Connie Sullivan. I'm the president and CEO of NHIA, and I want to thank you for attending this webinar and for your interest in this new program that NHIA is excited to be launching. You can go to the next slide, Jen. Our plan for today is to run through some information. Again, some of this is similar to what we put in our mini video that we used in the launch, but we want to expand on that information and tell you a little bit more about how the program works and give you some tools that you would be using if you enroll in the program. And then we will open it up at the end for Q&A, and you're always welcome to put your questions in the chat or in the question function, either one. And we'll look at those as we go along and try to get to as many questions as we can. We should have plenty of time at the end. So we'll go through the program overview. Bill Noyes will talk about enrollment and billing. Ryan Garst will talk about the clinical aspects of Bamlanivimab, which I'm going to call BAM from this point forward. We'll talk about our process for conducting the allocation. There are some data collection requirements and then additional resources that we're putting together for you. So you can go to the next slide. So this program came about through conversations that NHIA has had ongoingly with Operation Warp Speed and folks over at HHS, and also the Office of the Secretary for Pandemic Response, which is called ASPR. And you know, one of the challenges, well, there have been many challenges, let's just say that, with launching these products. But one of the main challenges has been that the allocations go through the states. And the state health department is supposed to identify providers that can facilitate distribution of these products and administration of these products. But as we know, the states have been very focused on vaccines, and I don't think they were prepared to handle these monoclonal antibodies. And therefore, the products really haven't been getting into the hands of the providers that can administer them out in the community or in non-hospital settings. And so one of the priorities for the administration is making sure that patients in skilled facilities, assisted living facilities, have access to all the treatment options, as we know, because those patients have been hardest hit by the pandemic. And so they've asked us if we could help with creating access to this very high-risk population. They are definitely aware that we are very interested also in home infusion, and I am always relaying back to them that there's a high interest in home infusion as well. And we have relayed also very clearly that the current reimbursement rate is a big challenge for creating home infusion access for patients to monoclonal antibodies that are only given one time. And so we are communicating on the home infusion side of things as well, and we're hoping that the administration will continue to work on addressing that by hopefully increasing the reimbursement rate for home administration, but we don't have anything definitive on that just yet. So with this program, we are going to focus on the facility patients first, but through that process, this pilot is focused on facility. Through that process, though, it may open the door for the states to finally be able to connect with home infusion providers that have the capacity to not only serve these patients, but through this demonstrate their ability to serve patients with monoclonal antibodies, and then open the door for a relationship directly with the state that would provide more flexibility in terms of where drug is administered. So you can go to the next slide. That's essentially what we're trying to accomplish. All right, so the program framework, as of right now, HHS is setting aside 500 vials a week for this pilot. They, you know, all the other allocations are going through the state, but this particular program will not go through your state public health department. It'll go directly from NHIA to HHS to AmerisourceBergen to the provider. The home infusion providers that receive an allocation do need to do some outreach on the ground to reach out to facilities in their service area and offer to provide these infusions to their eligible patients. And you can also offer it to their staff if the staff meet the qualifying criteria, meaning the staff you know, qualify clinically and have a payer source for the product. So it's not limited to just patients. Now, I'm sure we'll get to some questions about staff if you want to, if that comes up when we get to the Q&A. The infusions that are provided to Medicare beneficiaries are billed through the ABMAC COVID-19 vaccination program, which Bill's going to cover in a few slides. And then what we're going to be doing is creating a database that states can access to learn who the providers are in their state that can service patients with monoclonal antibodies and open up, hopefully, opportunities for you to work with the states directly on additional programs. You can go to the next slide. So in order to participate in this particular pilot, we've come up with a set of criteria that we think is fairly straightforward, and most pharmacies should be able to qualify. So if you want to participate, our goal is that that we're making it easy, hopefully, for you to do so. We are not limiting this to NHI members just because of the nature of the program. We want to allow anyone to participate that can serve patients. So if there's someone out there who's not an NHI member, but they have facilities in their area and they meet all this criteria, they're also eligible. So you obviously have to have a pharmacy license because you're handling the medication. We are looking for accreditation for home infusion, which should not be a problem for pharmacies that are in our industry. And that's just to show that each pharmacy participating is operating according to the standard safety and quality standards for the industry. But you have to be able to bill Medicare, so you have to be enrolled as this vaccine or immunizer, and then just be able to do what you would normally do for any other referral, perform an assessment for eligibility according to the emergency use authorization, obtain a physician order, coordinate the nursing for administration, dispense and deliver the product. And then we do have some data collection that we need to collect and report back to HHS. So we will collect that data from you, and then we will transmit it to HHS as well. And then there is a simple pilot participation agreement, which just sets out roles and responsibilities of each entity and releases each other from liability. Right, you can go to the next slide. So from a provider standpoint, these are the responsibilities if you participate in the program, is to conduct that outreach and try your very best to get the product out there. That's the goal. We're trying to facilitate getting you access to more product, but ultimately it is up to you to reach out to your customers, to the facilities in your area, and communicate with them that you're able to provide the service for them. And then assist that provider, or that facility, I should say, with how to get the information to you that you need to actually get the infusions performed. We would ask that you prioritize facilities that are in close proximity to your facility so that you can have a good response time. Once you receive a referral and you go through the whole process, if you can try to get to that patient within 24 hours, that's ideal, because obviously the sooner from the time of symptom onset that you perform the administration, the better the response and outcome probably for the patient. We obviously want to be able to include your company name on our website so that we can make your information available to the states who may want to do additional allocations. And then we will need you to collect some very basic data about where the product went and how the patient responded to therapy. You can go to the next slide. And then from NHIA standpoint, one of our goals is to connect the states with the home infusion providers, but also hospitals may be interested in allocating some product to home infusion. I know many hospitals received large allocations and have not been able to use all of the product they've received. And so through this whole proof of concept that home infusion providers can serve high-risk patients, we hope that hospitals may be willing to also provide some of their product to you. We also see that one of our roles is to facilitate the allocation, obviously, and we'll do that through HHS. And we also have committed to HHS that we would be making every effort to ensure equitable distribution across all HHS jurisdictions. And again, we want to make sure that we're reaching rural and underserved populations as well as metro areas. And we have had, I do want to say, I've been thrilled with the response we've received so far. I think we have, I've lost count, I know well over 130 pharmacies already that have expressed interest in participating. And we do expect to have enough product for every company that enrolls at this point. So we have seen that we have some very good distribution of providers as well. We have lots of rural areas that will be covered through this program. So we're very, very appreciative of the interest and willingness to participate. And then finally, our role will be to communicate with HHS how the program is going and providing them daily updates and the data. Okay, you can go to the next slide. So that's it from my portion. That's just a high-level overview. I'll go ahead and turn it over to Bill Noyes.
All right, thanks, Connie. As Connie explained, the goal of the NHIA's pilot program is really focused on expanding access to BAM for home infusion suppliers to meet the needs of targeted populations, in this case, nursing homes. In addition to enrolling in the NHIA pilot program, you're going to need to make sure you're enrolled properly with Medicare to bill for the administration of these drugs. So I'll be discussing how to enroll with Medicare, the various codes and rates, and claim submission process. Next slide. So when it comes to who can bill for COVID treatments, and when I say COVID treatments, the process and a protocol set up at CMS started with the vaccines, and they have tagged the monoclonal antibodies onto those vaccine policies. So if you see vaccine in any of my slides, much of the language is taken directly from the CMS websites. It also applies to monoclonal antibodies. There are a couple of nuances, and I'm going to point them out here. But CMS has really cast a wide net regarding the types of providers that can provide access to the COVID-19 treatments, vaccines, and the monoclonal antibodies. They're site of care agnostic, and there's a link here to the various provider types that can be involved in the provision of these therapies. So next slide. This slide shows the types of enrollments that need do nothing in order to provide and bill for the vaccine. They can do it under their existing enrollment. I highlighted here pharmacies enrolled as Part B, and this is enrolled with the ABMAC to provide drugs like Factor. Factor is billed to the ABMACs. It's not billed to the DME-MACs. So if you're enrolled as a pharmacy with the ABMAC program, you do not need to do anything regarding enrollment. You can submit claims under that provider type. And as you can see, there are lots of different provider types here, and they've cast a wide net. Next slide is the provider types that do have to take some action. Oh, I'm sorry, it's not. So if you're enrolled as one of these provider types that's currently eligible, you can submit claims using the professional claim form, electronic form that you normally would submit for the Factor products. You would just include some of the codes that I'm going to get to a little later on down in the presentation. Next slide. And for these types of providers, you do need to take action in order to bill for the COVID treatments, including BAM. If you're enrolled as a pharmacy with the DME program, but you are not enrolled as a pharmacy with the ABMAC, you need to get enrolled as a mass immunizer in order to bill for the monoclonal antibodies. Now, mass immunizers are normally around vaccines, but in this case, they apply to the monoclonal antibodies. You can do this by calling a hotline or completing a CMS 855B, but they've set up a hotline for very easy, quick, rapid enrollment in the program. Home infusion therapy supplier is also listed, but as we know, that's a new program. And many of those may not have a pharmacy attached or the ability to dispense drug, but I just wanted to point out that it was listed here. Next slide. As a mass immunizer, there are two different types. There's roster billing mass immunizers and central billing mass immunizers. Central billing relates to an organization that has 3 or more facilities in 3 or more different Medicare administrative contractor areas. So if you work, and I'll get to the map that you can see where those various jurisdictions lie. But if you may choose, if you have 3 or more in 3 different Medicare contractor areas, to enroll as a central billing mass immunizer, or you can simply enroll as a roster billing mass immunizer. Now, when it comes to roster billing, you do not need to roster bill for the monoclonal antibodies. That's one of the nuances that I mentioned earlier. For the vaccines and normal roster billing, you've got to treat 5 or more patients on the same day and submit that roster claim based on those 5 or more patients. When it comes to the monoclonal antibody, you are free to submit individual claims for patients. I think it's a lot less likely that you're going to see that volume of patients in a single day. So we have clarified that with CMS. It is also in the language on the CMS website, but we've clarified it and confirmed that with CMS. I've stated here, do not call the National Supplier Clearinghouse. If you look at the link to the hotlines to roster bill, the National Supplier Clearinghouse is listed for DME suppliers. They are not enrolling folks in mass immunizer programs, so you'd want to call your local MAC. Next slide. And this is a map of the AB MACs. You'd want to call the MAC based on where your physical pharmacy address is located. The service area is restricted within the MACs that you are registered, or enrolled. The hotlines are listed here for each of the MACs, as well as the hours of operations and the states that fall within each of the MACs. If you have a pharmacy in Florida, you can see Florida stands alone. It's the only state within jurisdiction JN. So if you have a pharmacy in Florida and a pharmacy in Georgia, you would need to enroll each of those with those MACs individually in order to provide service in those 2 areas. If you've got a pharmacy in Georgia and are looking to supply other states within JJ, you can do that, but you have to, you're restricted to serve the area within the MAC. Next slide. The hotline enrollment is temporary. It's meant to get up and running quickly, but when the public health emergency is lifted, there'll be a process, and if you don't respond and complete an 855 form, you would be de-enrolled in the program. So it is a temporary program. Next slide. So from a payment standpoint, Medicare has set up codes for administration of the vaccines and the monoclonal antibodies. This slide here is specific to the BAM. Payment is $309.60. And the code is listed here. If you receive the drug at no charge, you should not include the drug code listed here on the claim. You would bill for only the administration code. When you're enrolled with Medicare, you can bill for Medicare original fee-for-service patients as well as Medicare Advantage patients directly to the AB MAC. That's different than the norm. I have an open question out to CMS regarding what member ID to utilize in those claims for Medicare Advantage patients. I haven't heard back yet, but we'll update everyone with that information. Of course, the Medicare Advantage, they likely have a map behind the scenes where if you fill out the Medicare Advantage ID number, it will process, but I have not been able to confirm that at this point. There is no copay or coinsurance or deductible or any out-of-pocket expense for Medicare beneficiaries related to the COVID-19 treatments, again, both the vaccine and the monoclonal antibodies. And at this time, the drugs are at no charge. If there does come a time where it's a buy and bill scenario, CMS will reimburse at 95% of AWP. Next slide. So from a documentation standpoint, what do you need to have on hand in order to support the billing of this claim? We know Medicare always requires that you're able to support claims that you filed and payments you've received. And in this case, they're very specific as to what you need to have. You need to have documentation that supports that this patient met the guidance in the emergency use authorization as high risk. So there are a number of patient populations based on health status that are identified as high risk, and you'll need to be able to document that. I know that Ryan and Connie and everybody here at NHIA has worked to create an order form that Ryan will talk about that's got that really built into it. And I've got a slide here that shows what that criteria is as well. And in addition to that, and this is language straight out of the CMS website, the documentation also must include the name of the practitioner who ordered or made the decision to administer the infusion. And in this case for us, that would be the order. Next slide. This is a listing of the high-risk criteria. So you would want to make sure that any patient you administer the BAM to met one of these criteria, and it was supported in their medical documentation from the physician that they fell into that category. Next slide. So again, billing for COVID treatments, I wanted to point out, because if you look at the information online, it will continuously say roster billing requires 5 or more claims. But in the case of COVID the monoclonal antibody treatments, it is okay to submit, and they will accept individual claims. Next slide. When it comes to skilled nursing facilities, normally everything provided within that facility is billed by the facility as part of a daily amount during their Part A stay. In this scenario, Medicare is allowing other entities, including mass immunizers, to go into that facility, provide the service, and bill Medicare directly. That's important when it relates to this pilot program. It is outside of the norm, but an exception that CMS has made. Not for our program. This is related to COVID treatments overall, whether it's providing a vaccine in the skilled nursing facility or a monoclonal antibody. An outside entity can go in and bill Medicare ABMAC directly for that service. Next slide. And we have put together a one-pager, or it's a two-pager, that's got a lot of the details I've discussed here regarding how to enroll, how to bill, what needs to be on the claim, and what documentation that you have to have in order to support that claim. It's on our pilot program website, and the link is listed here. So with that, I'll turn it over to Ryan.
Okay, thanks, Bill. Thanks, everyone, for joining. I'm going to go over some of the clinical characteristics and considerations for the program, as well as the allocation process and the data collection process. So, Jen, you can go to the next slide, please. So some of you may have seen this before, but I want to go in a little bit more in depth. So again, our indications are for patients that are 12 years of age or older and at least 40 kilograms with that high risk of progressing to severe disease or hospitalization. And again, that severe disease, and I'll go over this a little bit more in detail with the order, but we've made it as simple as possible, looking at patients over the age of 65, those with chronic kidney disease, diabetes, immunosuppressive disorder or immunosuppressive therapy, patients that are 55 or years of older and then also have cardiovascular disease, hypertension. There's a couple other criteria. And then for patients from 12 to 17, they have to have a BMI in the 85th percentile based on the CDC recommendations. They have to be on asthma medications or respiratory medications daily, and a couple of other criteria that are listed out there. So I don't want to go too high into that, but it's a very important part of the process for qualification for the patients. to have, so in order to be able to get the drug. The dosing, again, is 700 milligrams, and we need to have that administered within 2 days of a positive test and within 10 days of symptom onset. Again, that's an important piece of the FDA EUA. And again, everything that we're doing with the medication has to be within the guidelines of the emergency use authorization for Bamlanivimab. Adverse events are relatively mild: nausea, dizziness, headache. But again, really, this is a monoclonal antibody. So I think the thing to remember is, with those that are administering these other monoclonal antibodies, it's going to have a similar profile in terms of adverse events and just in general for monitoring and things like that. So I think keeping that in mind is we've walked through the process here. That'll be very important. The preparation and storage, there's a couple of different things to talk about here. The EUA specifically has preparation and compounding instructions within it. Those are reflective of a total volume of 250 mLs, where you have to remove fluid from the bag and then add the drug to it. However, we'll be talking a little bit about some flexibility for healthcare providers on the next slide from Eli Lilly, that they issued a technical document and guidance for the industry and for providers that are going to be able to administer Bamlanivimab in a variety of settings. So we'll go through that. But again, this is the FDA EUA instruction. Storage at 7 hours at room temperature, 24 hours refrigerated. That does include the hang time of, again, 1 hour or 60 minutes. It is a protect from light, don't shake and freeze. Again, that's similar to other monoclonal antibodies. You do have to be somewhat gentle with the product, no vigorous shaking or anything like that. Administration, you do want to bring it to room temp, obviously, and it is a filter required medication. You can infuse it on a regular gravity line, drip, or dial-a-flow, or on an infusion pump. Again, 60 minutes is the infusion time. There is a requirement to flush the infusion line post-infusion to ensure that the entire dose was infused. And we are recommending using a 50 ml saline bag to do that. And then again, there is a monitoring period for 1 hour. So that monitoring would be similar to what your organizational protocol would be for that monitoring. So if you're monitoring from a nursing perspective is vitals and temp every 15 minutes while the infusion is going on, you would continue that for the 1 hour post-infusion. Jen, you can go to the next slide. So here is where I wanted to point out the Eli technical guidance. This is posted on our pilot website. It does differ from the previous slide, as I mentioned, and it does provide those alternative options for patient or for providers to have a little bit more flexibility. But a couple of the highlights from that technical guidance are: it is a normal saline only product. It is not compatible with dextrose, so you do need to use saline. It does allow some flexibility between 50 and 250 mLs of normal saline for the total volume, which again differs slightly from the EUA. And you don't have to remove volume from the bag in this instance underneath this technical guidance. It does discuss further compatibilities with other things like closed system transfer devices, elastomeric devices, and all of those types of things. You can look at that document for more details. But essentially, a lot of these things, it has not been studied, so they don't know. And so it's best just to stick to more of a basic process where you're going to be putting it in a volume and infusing it over that 60 minutes. It does list all the alternative administration and compounding materials that were used in the clinical studies. So that's a nice thing to take a look at, because it does have a variety of the compounding materials, syringes, needles, bags, tubing, all of those types of things in the materials that were used. And they do mention that it is not considered hazardous per OSHA. Up in the upper right-hand corner, I guess, if you're looking, is what the vial and drug box packaging looks like. I wanted to put that in there for folks that maybe have not seen the product, because there is Regeneron's product, which is not part of this program has a lot of different labeling, and it's a little bit confusing at this point, but Bamlanivimab is pretty straightforward, has an NDC, has a vial, all of those types of things, pretty clearly labeled at this point. The other part of the slide here are the suggested supplies from the Operation Warp Speed Therapeutic monoclonal antibody playbook. I think most of us are aware of these supplies, but I did want to put it out here. It's not an exhaustive list, but it does list sort of the recommendation for making sure you have products for the reconstitution if you are going to mix it bedside, or what you would need to infuse and things like that. So it's a little bit more geared towards an infusion like an infusion center, but I did want to include it for completeness because it does have some of the product or the items that you would need to actually do the administration of the infusion anywhere. Next slide, please. So again, I want to quickly go through this, and really one of the most important things in terms of a reporting structure is serious adverse reactions must be reported to the FDA via the MedWatch program. Serious adverse drug reactions are defined as an event that causes death or a life-threatening event, requires an inpatient hospitalization in this point. Again, these patients are in a SNF, so not prolongation, but for completeness, I wanted to put the definition there. And then the last ones are probably going to be a little bit maybe not as applicable to our program here, but again, for completeness, a persistent or significant incapacity or a substantial disruption to their quality of life or normal functions, a congenital anomaly or birth defect. I don't think we have to necessarily worry about that in the population we may be treating. And then either a medical or surgical intervention to prevent death, a life-threatening event, hospitalization. Again, these are a little bit more, it's more exhaustive or a longer list of items, but we're going to be really looking at, and we'll talk a little bit about this as we go into data collection at, you know, a serious adverse event with death or hospitalization are probably going to be a couple of the things, or an emergency room visit that we'll be looking at. Next slide, please. And again, I'm not going to go through the specifics here for sake of time so we can get to questions, but this is how you would report a serious adverse event, and it must be done within 7 days. This is required per the federal Drug and Food Administration or Food and Drug Administration, EUA. So you definitely want to make sure that you are reporting these things based on that definition provided, and that is specifically outlined in the EUA document as well. So just this is the form and how you complete it, and it can be done online or via paper. But again, must be reported serious events and must be done within 7 days of the suspected event. Next slide, please. Okay, so now we're going to move into the product allocation process and how that works. You can go to the next slide, please. So I sort of broke this up into two sides here, what NHIA will be doing in terms of the allocation process, and then what HHS, AmerisourceBergen, and the enrolled providers in the program will be doing. So NHIA will weekly be sending out a survey monkey that will be due by the close of business on Thursdays, and we'll be asking of those providers that are enrolled the number of doses that are available, so the doses that you have on your shelf less any committed doses. So if you have 9 doses on your shelf, but you know tomorrow on Friday you're infusing, you would have 8 available. And we're going to put some more of the definition of how to that number of doses available in the survey monkey for you. But we want to make sure that we're getting an accurate count of what you have on hand. The number of doses infused, again, just if you had 6 infusions this week, we want to know for a data collection purpose. The number of doses that you maybe had to waste, we know that occasionally will happen, so we do want to know that. And what you feel based on your need as you ramp up the program and as you're getting more patients, what you would like to have as a requested amount. We may end up sending a little bit more, a little bit less, depending, but we want to have an idea of where you think that you'll be able to move off the shelf, because obviously the idea is to not let the product sit on your shelves. it will be final allocation from us will be due to HHS on Fridays. And again, I think Connie touched on this at the beginning, but we are going to be looking at your usage, obviously, and also geographic reach. So we want to make sure that we're covering as much of the United States as possible, those 10 HHS regions that are part of the program. We want to make sure that we're doing that. And then you will receive an email from NHIA with confirming what your allocation number will be for that week. So now we'll move over into what HHS, ABC, and oh, go back one more slide, Jen. Sorry. So what HHS sends for the enrolled providers, we will send it to HHS. HHS then sends it directly to ABC. The state is not involved in this process. So I think Connie and Bill both mentioned that one of our goals of the program is to identify providers that are able to provide these medications to be able to allow states to do allocation as we move forward. And then ABC will then deliver the product directly to you at your locations on Monday or Tuesday. I say Monday or Tuesday because it's still new, but it'll be Monday or Tuesday early in the week. So therefore, that's what you can expect. And then again, talked about the survey. We'll need that survey due back by about Thursday, or it'll be due at close of business on Thursday so that on Friday we can work on our allocations. So next slide. So now we're going to go into data collection and then the program tools that some of them we have completed and some of them we're still working on that'll be coming very shortly by next week because we've been ramping up so quickly with the program. So we can go on to the next slide. So this is the required to report outcome data. This is, again, based on the fact that the drug is still in an emergency use status from the FDA. So what we need is the patient age, gender, race, and ethnicity. We will need the long-term care facility information. So I guess you could say the facility demographics, address, location, and their CCN or federal provider number. We will need the infusion date. So obviously it's a 1-hour infusion, that the infusion was completed so that there was no reason for maybe you administered, a dose and then the patient 30 minutes in didn't seem to tolerate it, so you decided to stop it or whatnot, whatever that may be. Hopefully that number will be, if you have 10 doses and you did 10 infusions, all 10 were completed. That's what we're hopeful for. And then another big important thing will be the 7-day follow-up, where we are assessing emergency room visits, patient hospitalizations, or patient deaths within 7 days of the infusion date. So that is similar to some of the other requirements for reporting and some of the other programs that they're using with the monoclonal antibodies. And again, we need that reported within 14 days to NHIA. So if you have an infusion on the 1st, let's say, we would need that data by the 15th. So that's what we have for there. And then I just put in that little bubble because it's not required to report to NHIA, but again, serious ADRs are required to be reported to the MedWatch program of the FDA within 7 days of that event. So again, I put it here because I don't want to lose track of that because that is required data to report, but that would go to the FDA, and the rest of this information that's on the left-hand side of the slide would come to NHIA directly. Next slide. And this is some of the information that's going to be ideal to report. And again, we are going to create a very simple data collection tool for you. It's really just going to be an Excel spreadsheet, nothing fancy. There's no reason to get all the bells and whistles. So we are going to add this information to that data collection tool, but this is ideal, not required. So again, I put in there all the required data again, plus this ideal data that we would like to present. Some of this information and I guess really all of this information would at some point be documented within your electronic medical record system. So the data from before, this data, that's really all going to be documented. And even our standard order set will be helpful with some of these data points that are both the required and ideal to report, as we're calling them. So again, the ideal would be the symptom onset and date of the positive test. The qualifying criteria descriptors. So what I mean by that is, what did the patient have that put them at a high risk population for administration of Bamlanivimab? The product lot number and expiration, which obviously would be compounded because you are going to be dispensing this through your system as a normal prescription and physician order. And then if the patient did have any mild or moderate events, and the date of the event that would have occurred. So again, these are some of the additional pieces of data we would like to collect. But again, they're not required. The required data was on the previous slide, highlighted in green, that needs to be reported to NHIA within 14 days. So we tried to keep it as minimal as possible with what we were being asked to get. So next slide, Jen. So on the right, I know it's small, but it will be posted, is our example order form. And essentially it has a lot of the information at the top, the facility information, the date of symptom onset, the date of the positive test, the exclusion criteria, which I didn't really go into, but exclusion criteria would be the patient is hospitalized, which again, we included that per the EUA. Again, that's patients that are hospitalized, patients that require oxygen that are hospitalized, and then also any patients that are on supplemental oxygen that would require an increase to their baseline. So again, that's in the EUA. And then we have the high risk criteria listed. We also then have the order for Bamlanivimab, as well as the 50 ml bag for the post-infusion flush, flush orders, vascular access to orders for nursing to either insert a peripheral line, or to have, if they have, the patient has a line that's already in place, to access that line to administer, and then the pharmacy and nursing clinical services that we would be providing. So it's very similar, and it captures really everything you would need for documentation. Again, for Medicare, sort of as Bill talked about, in some of those documentation requirements, as well as documentation requirements for the data. So the tools that we have, again, are the pilot program website, which probably most of you have seen. We are finalizing our clinical resource guide that will talk about criteria and how you do that, the preparation and administration, the 7-day follow-up example, and we'll have that information posted very soon, early next week at the latest. The order template, which is on the right here, you can see, again, small, but that will be posted on the website by the end of the day today. The data collection tool, again, will probably be ready, early next week, Monday. But again, probably, but definitely before you would have product and get it start to infuse by, probably mid to next week. We are going to have weekly office hours like this. This week, we really wanted to go over a little bit more in depth, like we're doing today, just to give you a little bit more nitty gritty based on the previous webinar we posted. We are going to have holiday office hours on the 23rd and 30th due to the holiday, and those will be at 10 a.m. But just wanted to point that out, that because of the holidays on Fridays and how they run this year, we'll have it on the 18th and then the 23rd and the 30th. And then there will be a link on our website that you can go in and log in and be automatically ready and registered for those office hours. And then we also have a section of the website that has all of the monoclonal antibody resources, from Operation Warp Speed, from Lilly, and all of those types of things. And then at any time, you can submit your questions to info@nhia.org. Jen Sharon and I will be, and my name's Ryan Garst, I'm the Senior Director. We will be managing more of the logistics. Bill will be available for questions about billing and enrollment. But again, send all of those questions to info@nhia.org, just because we're all sort of tag teaming that. And if one of us is away, we're really going to try to get back with you as soon as possible. So if it goes to that info, then someone can grab it and then get back to you as soon as possible. So with that, I think that was the last slide, Jen, right?
Yep. Yeah,
okay.
so we have a bunch of questions coming in. So again, just go ahead and register for the office hours. It will register you for all of our office hours all the way through the end of January. And that's the most up-to-date information because, as we all know, things change fairly quickly. So just going to kind of run through these. One question was that Eli Lilly had retracted the alternate compounding recommendations. And so states are going with the EUA. Is that correct?
So based on some of the calls that we've had during the program, they stopped distributing it for the public because they have submitted it to the FDA for updates to the EUA. It would be our recommendation to still stick with what's currently in the FDA EUA. I included it here just for a little bit more information for you guys to have and know just from a clinical perspective, because there was a lot of questions about, well, can I use dextrose or those types of things? And the EUA doesn't specifically get into that. So we're hopeful and we're waiting to see if the FDA is going to update the EUA to reflect some of the technical guidance. But that was a little bit just of additional information. But our recommendation would still be to stick with the preparation and administration instructions that are in the EUA. But if there's an issue with a bag size or getting the a different type of filter and things like that, or can I use this kind of syringe for it? I just wanted to make sure you had a little bit of background clinical information there.
Great. On the allocation, so when we're talking about 500 doses, we're talking about NHIA's total allocation, so that wouldn't be to a specific site. We are anticipating that we will have drug for everybody at this point. So I just wanted to be able to clarify because there was a couple of questions there. I think this one's probably for Bill. So they have one pharmacy in the WPS MAC, but shipped to Illinois. Do we need to enroll with NGS also in order to ship there?
Yeah, as I explained, there are limitations around service area, and it's restricted to your physical address. So the physical address of the licensed pharmacy. If you don't have a licensed pharmacy in Illinois, you wouldn't be able to provide services in NGS area. It's different than HIT services, and I don't want to get into that. They're allowing for expanded coverage, decentralized services. But with this program, it's restricted to the MAC that you're physically located in. If you have a location in NGS, you would enroll that location in order to service Illinois.
And I think too, we're really looking for kind of that local coverage area so that you can qualify that patient and do every effort to be able to infuse the medication within 24 hours. Will the drug be delivered with traceability reporting?
Yeah, I saw that question. Let me get back to you on that question. I want to make sure I'll get you an answer to that, and we'll get that information back. That's a great question. And I know that there are different state board requirements with that. So thank you for bringing that question up. That's one that we hadn't thought of right off the bat. But I will get back with you once we get some information and get that posted.
Right. And I can take this one. How are we handling the requirement to prepare for potential reactions during infusion? So I think that's going to be really site specific. I think there are some SNFs who have that available. And there may be some assisted living facilities where the provider would be bringing that with them. So I think that, you would be treating the reactions as you would any reaction. And we've posted some information about anaphylaxis as well as other reactions and how to manage those, but that's really going to be site specific based on what you have available at that specific site. Okay, this one's going to go to Bill. So who do you bill if the patient doesn't have Medicare?
You would have to get in touch with the payer and see if it's something that they cover. We have reached out to CMS to see if we could bill the AB MAC regardless of payer, specifically asking about Medicaid programs, commercial programs. So you would have to check with that payer, go through your normal process to qualify a patient.
Yeah, we are encouraging folks to run patients through your normal intake process just so that all of that information is covered. All right. Is there a way to administer BAM and bill using the new codes if we get it from another source like a hospital?
Yes. You would use the same process to bill regardless of how you obtain the drug itself. So what I reviewed as far as enrollment and billing is applicable to the entire, all COVID treatments, even outside of the NHIA pilot.
Yeah, correct. All right, and then the last question we have for today so far is if we're registered with the AB Max for infusion, does that cover us for vaccine or would they need to reapply?
If you're registered with the AB Max for infusion, I'm not sure I understand that question. If you're enrolled with the AB Max to provide Bamlanivimab, you would be able to also provide the vaccine. You would bill different codes. I didn't include them in this presentation. They are included in a previous Talk Infusion presentation, but they go hand in hand. All of these COVID treatments are being run through the same program as it pertains to enrollment and billing and claim submission.
Thanks, Bill. And if to the person who answered that question, if that didn't cover your question, please feel free to send that via info@NHA or clarify during in the question tab, and we'll get back to it. A couple other questions coming in, and I'll take this. Could we provide the drug and then partner with local home health to administer the drug? Essentially what people are asking, we have a few questions about this, is can you subcontract the nursing? That's absolutely you can. That is totally up to you how that billing. We have also seen providers who were looking to either subcontract or buy back the skilled nursing facility nursing staff if in fact they could also administer it and be able to have the drug just delivered without using their nursing staff. And I think as we move through for some of these office hours, one of the things we're planning on sharing is how providers are actually implementing this, because I think there's a large variety of ways that folks are working with their skilled nursing facilities or assisted living facilities and how they're implementing the program. So we're going to share some of those ideas in some of our future office hours. All right, and then, okay, Bill, are we anticipating any prior authorization rejections? I don't know if you can answer that.
There is no prior authorization process for Medicare. If there is with a commercial payer and you got an authorization, I wouldn't anticipate a rejection. But there is not a prior authorization process for Medicare for this program.
I think we've talked.
When I say program, I'm sorry. When I say program, I mean for the billing of COVID treatments.
And I would agree, Bill. And I think the other thing we've been talking to providers who are enrolled in the pilot thus far is documentation is key, and ensuring that you have documentation that supports the use under the EAU. And that's why we've kind of developed those order forms, whether you put that in your system as an order form or whether you use it as documentation, however you use that. But making sure that the patient fits the criteria, I think, is going to be key. And then we have a question here about when we're expected the first doses to be delivered. So we have set up calls with folks who have enrolled in the pilot thus far. We do expect to be able to have doses delivered to those folks who are enrolled by Monday or Tuesday of next week. So we're working with those through the end of today, and we'll be sending out those who are enrolled their allocations over the weekend so they know how much to expect, and then their delivery should be early next week. I think that's our last question that we have for today. Again, I just wanted to remind people, this office hours will be every week, and it's a great time to get updates and be able to ask any questions specific to your program, as well as we'll be sharing some of our best practices or some of the successes that our pilot program has been having. And again, any question, just send that through info@NHIA, and either Ryan, myself, or Bill will get back to you on an answer. We might have to research it a little bit, but we're dedicated to ensure that you can successfully implement this pilot. So feel free to reach out to us at any time. And with that, I'm going to end.
And Jen, I would add before we end that we've got some good lines of communication with CMS, provider integrity, program integrity, I'm sorry. And they're the ones responsible for standing up this benefit and ensuring that all that can access and deliver these services are able to bill for them. So if you have issues with enrollment or with claims processing down the road, feel free to reach out to us and we'll use those lines of communication to help resolve issues. We've been able to do that. CMS has communicated with the various MACs regarding some bad information that was being given to help educate them on this new program. There's 12 AB MACs and CMS is giving them information to stand up very quickly. So understandably, there's been some confusion along the way, but if you have specific issues, reach out to us and we'll do our best to help resolve them.
Absolutely. That's a great point, Bill. All right, everybody. So this is being recorded. The handout as well as the recording will be available via the NHI website under our BAM pilot webpage. Again, thank you very much for participating and your interest. We're happy to answer any other questions that you might have. And everybody have a great day. And thank you so much for your support of our home infusion patients and ensuring our patients can stay home in the safety of their home. Enjoy the day all, and we'll look forward to talking to you next week.